Hello dear viewers, in this video which is part 13 of continuous renal replacement therapy, I will be discussing part 7 of regional citrate anticoagulation where I will discuss energy management while using regional citrate anticoagulation in CRRT. How the use of regional citrate approach for anticoagulation during CRRT affects energy metabolism in critically ill patient in ICU. This is last video in the series of regional citrate anticoagulation. In the energy management of patients with renal citrate anticoagulation during CRRT, the extra calories provided by this anticoagulant approach should be taken into account. Citrate is not only an intermediate product in the tricarboxylic acid cycle but also can be directly oxidized and decomposed. Complete oxidative decomposition of 1 millimole of citrate in the body can produce 0.59 kilocalorie of heat. In addition, the additional glucose provided during anticoagulation with ACDA also generates heat. Complete oxidative decomposition of 1 millimole of glucose produces 0.73 kilocalorie of heat. As you can see here, while 4% trisodium citrate provides citrate as energy source, ACDA solution provides glucose additionally. Hence, caloric contribution of ACDA is more than trisodium citrate. While in post-dilution CVVH mode, the clearance ratio of citrate calcium complex is around 32% and the remainder goes in patient circulation. The same is more in CVVHD mode. In CVVHD, clearance ratio is around 48%. Additionally, the amount of energy substrate entering the body varies with the use of different replacement fluid or dialysate flow rate as it affects the clearance. Therefore, regional citrate anticoagulation can have an impact on patient's caloric management. Anticoagulation alone can generate somewhere between 350 to 900 kilocalorie extra per day, which should not be ignored but be included in the overall nutritional management of patients. However, due to the CRRT mode, treatment dose, different replacement fluids and different anticoagulant composition, the extra calories provided by regional citrate anticoagulation are difficult to accurately estimate. In addition, the effect on energy management is more complex when different formulations of replacement fluids are used, such as lactate replacement fluid, as complete oxidative decomposition of 1 millimole of lactic acid produces 0.33 kilocalorie, or if high glucose replacement fluids are used. So to summarize, the extra calories provided by regional citrate anticoagulant approach should be considered in total caloric management of patient. The amount of energy substrate entering the body varies with the use of different replacement fluid or dialysate flow rate as it determines the treatment dose and affects the clearance, therefore altering the amount returning to systemic circulation. As we have seen, it also varies with the mode of CRRT as there was different clearance in CVVH and CVVHD mode, hence affecting the quantity of energy substrate entering into systemic circulation. We have already seen the energy substrate provided by different anticoagulants. In terms of energy substrate, ACDA provides more calorie than trisodium citrate as it additionally contains glucose. And lastly, type of replacement fluid may also impact this calculation. If it contains the lactate, as lactate also provides calorie, or if replacement fluid contains glucose. Therefore, renal citrate anticoagulation can have an impact on patient's caloric management. Anticoagulation alone can generate somewhere between 350 to 900 kilocalorie per day. Here I finish. Hope this video is useful to understand the nuances of regional citrate anticoagulation. If you have any question, please write them down in comment section. See you in my next video on CRRT part 14. where I will discuss drug dosing during CRRT. Till then, bye and take care.